Protocols surrounding imaging continue to evolve as we learn more about the COVID-19 pandemic. Earlier on today, I spoke remotely to Dr. Gupta, a radiologist at University Hospitals Cleveland Medical Center, to learn more about how clinicians are adapting their use of X-ray systems during these turbulent times.
It's an incredible privilege to me to chat with someone like you, with your background, with your experience, especially when it comes to the context of diagnosis of COVID-19. What does a day-to-day look like for you?
It started like a very scary thing to us, but slowly we have adapted to the situation, and now we know that and we are kind of getting more used to the procedures and the methods in place, keeping ourselves and the other people in the vicinity safe, and at the same time provide the clinical care to the patients.
When a patient presents to you, when and why are you using X-ray?
So that's a great question, Mikey. So the first contact of the patient is with the frontline workers, like who just take the clinical history, which is very important in this patient group. So after the history taking, and if the clinical team determines that there's a need for imaging as per the guidelines that we have also provided them, the patient goes to the radiology department, or we provide them a portable radiography service, and based on that, the imaging is performed. And between CT and plain radiograph or chest X-ray, what we choose is dependent upon how severe the illness of the patient is, because as we know that the chest X-ray is insensitive in the early part of the disease, and that is all the data that came from China. But as we are seeing the new data from New York, as the stay-home guidelines are in place, so more and more people, they reach the hospital in the advanced part of the disease, and which makes the X-ray a better imaging modality because it picks up more disease than was initially posted. So basically, our inclination is to use more and more X-ray, and particularly speaking, mobile X-ray units are playing a big role here, because we have isolation rooms in our hospital for these COVID-19 patients, and bringing that COVID-19 positive patient into the radiology department can increase the risk of transmission to the health personnel. So what we have started to use is like the X-rays machines, the mobile X-rays per se, we take them to the isolation room and take the X-ray there, decontaminate the machine, and we are done with that.
So the mobile X-ray isn't just allowing you to treat patients at bedside, it's ameliorating the risk of contagion through yourself and to your medical staff.
Exactly. And we are also trying newer techniques like imaging from the glass or imaging outside the room. So this is something which is coming up, and we just started it a few days back, like 2 or 3 days back, so as to further minimize the risk of transmission to the healthcare personnel. So what we do in this method is the technologist stays outside the isolation room, and the detector or the sensor in the X-ray machine is handed over to the person who is taking care of the patient, and that detector is placed behind the patient, and the X-ray is flashed from the outside the room.
What is the advice that you have for the protocols, the best protocols, and the best systems that have enabled you to weather this crisis?
Yeah, so the protocols are in place. So the thing is, like, there is not a single advice that is valid at all the times when a pandemic is ever evolving. It changes every day. So the best advice is to keep track of the recent guidelines, how the disease is evolving, how disease is spreading. So you have to, I think it calls for innovation, right? So you innovate every day. So we initially thought like, oh, we got CT scan, which is the best thing in the town, and we will scan all the COVID-19 patients on CT scan. It has a superior kind of sensitivity and specificity. All the papers and all the literature is filled with it. But soon we realized like CT imaging is very, very tricky, and it comes with a logistic challenge as well. To clean the equipment, to clean an entire CT suite is a big task, and it takes like on the tune of at minimum 30 to 45 minutes as compared to a radiograph, which has a lower sensitivity, but definitely you can clean it in 5 to 10 minutes. So definitely you can take the mobile unit to the patient. You cannot take a CT scanner to the patient. So that's how we have now changed. So that's how the policies have changed over time, and that's how the things have evolved. And we are now moving more towards doing plain radiographs or chest X-rays on these patients, especially for triaging as well as assessment of the response to treatment.
Your insights have been fascinating, and please be safe.